Thank you for joining us for Conversations and Cases, integrating recent progress in the treatment and management of relapsed refractory myeloma. During this segment, we'll be discussing a 55-year-old patient with a relatively standard relapse and no comorbidities after initial treatment and transplantation. My name's Dr. Paul Richardson, and I direct the clinical research program at the Jerome Myeloma Center at Dana-Farber Cancer Institute. And it's my true pleasure to be joined by two outstanding colleagues, Dr. Berdeja and Dr. Saad Usmani. And in this context, let's just quickly discuss our case before we move into discussion. So in terms of the actual case, this is a 55-year-old lady with relapsed myeloma and no significant comorbidities. Just simply to give you some texture, she was diagnosed approximately 4 years ago, treated with RVD induction remission treatment, underwent autologous stem cell transplant, achieved complete response, and was not part of a clinical trial, so MRD status at that time was not assessed. But nonetheless, she went on to lenalidomide maintenance, which she tolerated well, and has continued on that now for 4 years. In that context, she now has developed a new lytic lesion detected on plain radiology because of some symptoms related bone pain. Her serum M protein has also increased. Bone marrow aspiration and biopsy has revealed a plasmacytosis consistent with an increase over and above her prior measurements. And in that regard, she has evidence clearly of relapse. So obviously, as we recognize, relapse is inevitable in myeloma, and so considerations in terms of relapse are very important. And I think what's important to share is that early relapse is a clear area of absolute priority. Best choices in early relapse really do have an impact on outcome. And as we think about that, it's worth mentioning that the attrition of patients during the treatment course is particularly important to bear in mind. And so when we consider treatment choices in early relapse, there are a few points to just make. One is, of course, disease related. In other words, the pace of disease progression, the features of any aggressiveness, whether or not there are circulating plasma cells, and for that matter, is there the presence or absence of end organ damage, which there is in this lady's case. Bone marrow reserve at relapse in this particular patient's case is actually quite satisfactory, and she's 4 years out from her transplant, so very much in keeping with the typical timeline for relapse post-transplant. And her cytogenetic profile we can discuss in a moment. But in terms of her therapy-related options, she's had RVD induction remission treatment. We can think about her transplant status, i.e. she's had an initial transplant, and she's now 4 years since first. She tolerated her treatment well, as I've mentioned. And then, of course, there's the availability of novel agents and accessibility to them in the context of treatment choices. And in that regard, she has a plethora of options to choose from. Now, in terms of patient-related aspects, the functional age of the patient is very important, of course, as well as performance status and comorbidities, and above all, their healthcare-related goals and preferences and socioeconomic factors that we should bear in mind. So I'd now like to turn to Saad and Jesus to discuss considerations in terms of treatment choices. And in that regard, I'd love to, Saad, to hear your thoughts about how you might approach this patient.
Thank you so much, Paul. I think you've, summarized the key issues in this case quite well. This patient relapsed, in the usual fashion, appears to have had standard risk kind of myeloma. I would characterize this patient as being proteasome inhibitor or bortezomib exposed, but not refractory. And since they've been on len maintenance and tolerating it fine and progressing on it, I would consider them as len refractory. The good news is it appears that they have good performance status and they're still young. So in terms of looking at options for this kind of patient, standard of care, I think, picking an option that does not include lenalidomide, so really looking at len refractory kind of options would be the way to go. And, the other potential consideration, again, in a young patient, who had, 4 years of PFS benefit, we can also talk about, the potential role for, a second auto in this scenario. But again, there are so many different options. I'd love to, get Jesus's take here as well.
Thank you. And Jesus, please.
Yes, thank you. Okay, so so as been summarized before, this is a center risk patient, and they've been exposed to bortezomib and lenalidomide and transplant, and are relapsing on lenalidomide. But I think it's a good. Saad made a good point about this patient relapsing on len maintenance. But as we know, a lot of our patients often come off lenalidomide for many reasons: choice, for toxicity, for others. So I think the question becomes, if the patient had been off lenalidomide and relapsing now, would we still be comfortable going back to len containing regimens? And I would argue that those would be in play for someone like that. But in someone who is relapsing on lenalidomide, I do agree with my colleagues that I probably would move to a len sparing regimen. And here I really feel this patient has not seen the anti-CD38 antibodies, and I think the anti-CD38 antibody combinations are probably the strongest data. And so I think daratumumab or isatuximab with carfilzomib in this fit patient probably would be my number one option for her, but very many others I think are possible as well.
Yes, I'd agree. So I think we were keeping that cytogenetic question in reserve just to share with our audience about how that might impact upon what we would be looking at. But I will say that this lady actually had standard risk cytogenetic profile at relapse. Really, at initial diagnosis, she had trisomy. She had no adverse features. She would be considered someone who would be standard risk at diagnosis. And then at relapse, there was no major change detected. In fact, she continued to exhibit trisomy with no adverse or worrisome features, no 1114, which might have been a targetable process, and certainly no emergence of 17p or anything adverse. So a kind of standard risk, relatively decent progression-free survival interval. I agree with Saad that one thought might be, obviously she got 4 years from her first autograft, would there be any role for a second? But I agree with you, Jesus, that with the advent of obviously multiple choices, I personally would favor a proteasome inhibitor, not least of which because, as Saad pointed out, she hasn't seen bortezomib for some time. She's got lytic bone disease as an area of progression. I always like to think of proteasome inhibitors being very important in the setting of bone disease. And at the same time, obviously, as you absolutely correctly point out, she's CD38 naive. So in this setting, I personally would agree with you. I would favor carfilzomib combined either with daratumumab or isatuximab. I guess, Saad, the next question would be, what about pomalidomide? Where would you position or think of pomalidomide in this setting?
No, this is an excellent question. I think if you look at that first relapse setting, there are single arm data sets that tell us that patients can get a reasonable PFS from a daratumumab pomalidomide dexamethasone based approach, or isatuximab pomalidomide dexamethasone based approach. But I think here we have the advantage of making that class switch. Someone who's been on an immunomodulatory drug, I think I'm in agreement. Going for a PI based, carfilzomib based triplet with an anti-CD38 makes sense. And this way, one can keep a pomalidomide based option in reserve. We always have to plan for the next step, and what might happen down the road. So there are other options with pomalidomide combinations like POM cyclophosphamide dexamethasone or elo-POM dex, that one can potentially utilize in the future for those patients.
Right, I think that's exactly right. And I think the other point, of course, is that I should mention she doesn't have residual neuropathy from bortezomib. So as you point out, the sequencing would be really interesting, and certainly revisiting potentially a proteasome inhibitor even after carfilzomib, isatuximab or daratumumab would make great sense with or after pomalidomide as well.
Do you mind if I ask a question of you guys?
Yeah.
So keeping in mind the studies that were done with the patient population, so we're all favoring a anti-CD38 combination for this patient. If this patient had been treated with the quadruplets, so let's say they got daratumumab, lenalidomide, or bortezomib dex prior to transplant, how would you feel about going back to a dara or ISA containing regimen? Does that change your mind?
I wouldn't change my mind, with the same caveat that patient was exposed to both a proteasome inhibitor and an anti-CD38 for a defined duration of treatment, and that was 4 years ago, or 4 or more years ago. I think it would be reasonable, at this point, 4 years post-transplant for patients to be re-challenged with a proteasome inhibitor on an anti-CD38 in an effective combination. And I think this is the point that we have to make with our colleagues. Just because patients get quadruplets, doesn't mean that they cannot get the same components of that regimen later on if they have had a prolonged absence of exposure to those therapies.
Yes, I agree. And I think that the very interesting question would then arise, though, if that patient had been on, say, daratumumab maintenance on a monthly schedule for some time, would you then start to think, even though recognizing this patient has standard risk features at relapse and a decent PFI from her prior transplant, where would you think about BCMA-based therapy now, Jesus, in this setting?
Yeah, no, I mean, I think that's an excellent question. But, just going back to, I think just bringing the point again that Saad just made about sort of exposure versus refractoriness. So just because someone's been exposed doesn't mean you can't go back to the same agent.
Right.
But I agree. If you are triple refractory, if someone is, even if it's in second line, they're progressing on daratumumab, bortezomib, let's say, that's a triple refractory patient. And I personally believe that those are the patients that should be getting BCMA-directed therapies.
Right.
But unfortunately, currently, as standard of care, you would not be able to do that, as the indication for all of our anti-BCMA therapies is 4+ lines of therapy. But definitely a clinical trial would be my recommendation if available.
Yeah, and I agree. And I think, I like the strategic view here. This lady has favorable prognostic features. There's nothing here that should be concerning to us in terms of obviously recognizing, despite the necessary aggressiveness of relapse after transplant, perhaps being an important consideration. I think a PI plus CD38 next, having POM in reserve for a next line makes a lot of sense to me from the point of view of a sort of strategic view of what to do after first relapse. But what would you suggest in terms of, would you think it ever in a setting like this of, for example, our own clinical trial we did with carfilzomib, pomalidomide, dexamethasone, and daratumumab? We currently, our own data in this setting suggest a 95% response rate with really encouraging durability. Are there settings in which, for example, Saad, you might bring your pomalidomide early and do KPD Dara, for example?
I think if we saw this patient presenting with high-risk features, with either circulating plasma cells or some high-risk, karyotypic abnormalities that they have picked up, I would favor, for a young patient like this, a bit more aggressive approach. In fact, we actually have, a very similar kind of a study here at MSK, which we're calling Second Chance, where, for these kind of patients, we employ a similar kind of an approach. So I'm in agreement. I think for those kind of patients, going for a more, aggressive approach based on disease biology would be a reasonable choice.
Now, if just to flick it a little bit, if, for example, this was a patient who said, I'm a busy, hardworking person, I've got a lot of family commitments, is there an all-oral approach that we could embark upon so I don't have to come to the clinic on a weekly basis? And I'd really like to explore an all-oral approach. Jesus, any thoughts on what you might want to deploy in that situation?
Yeah, absolutely. And I think, we all kind of struggled with that during the COVID pandemic, right? Where we kind of wanted to minimize time in the clinics. So I think the oral options are always good. And that goes back to the patient choice, which is very important, right? Maybe this patient's still working and kind of would prefer that kind of combination. So definitely there's the data with ixazomib, lenalidomide, dexamethasone is good. Again, this patient is relapsing on lenalidomide, but it's a maintenance dose. So you could argue perhaps you could try that. More likely, I would probably then incorporate pomalidomide. with ixazomib and dexamethasone as the next best option for this patient.
Yeah.
Yes, absolutely.
And we do have data for that, right, Paul? So, that's the Peter Voorhees study looking at ixa-PomDex versus pomalidomide dexamethasone. Even though it's a randomized phase 2 study, I think, that it does provide us evidence that combination actually is efficacious in addition to PomDex. So I think that would be another, potential option for, if the patient was really pressed on, going for an all-oral option.
I completely agree, Saad. And that study, as you know, is an alliance trial in which we assign patients to PomDex versus ixa-PomDex. And this was a once-a-week dosing of ixazomib with pomalidomide, and our median PFS was in excess of 20 months for the triplet, compared actually to just 7.5 months for the doublet. So a very striking clinical benefit. And we had, to your point, Jesus, we had no COVID mortality, and this study enrolled during the peak of the pandemic and was, well sized. So randomized phase 2 for sure, but adequately sized, adequately powered to inform practice. So an excellent guide in that regard. So thinking ahead in terms of lenalidomide refractory disease and the opportunities to then go forward with other studies, I think there are a variety of other options that could be thought of as well, aren't there? And certainly they would be tailored to the patient needs. So I think I will stop there and we'll move on to our next conversation. But thank you again for joining us for this segment on a 55-year-old lady with early relapse and no comorbidities. And please be sure to click on the landing page for this activity to claim your AMA, ANCC, ACPE credit, access supplemental slides, as well as other topic segments and case scenarios. Thank you very much.